Okay, when we begin our 10-point must or predictive type of biomechanical examination, which is really an abbreviated exam so that we can do it in a time-efficient manner, but still get the most information for our treatments, whether that's a conservative or a surgical procedure that's intended. First thing I like to do is just to get a general feel for the patient's postural evaluation while they're sitting. And oftentimes you'll get a sense of hip rotation, knee alignment, just from looking at the patient when you initially come into the treatment room. So when we start, we look at the foot position just to say, are the feet out, which would probably indicate the patient has a lateral or an external neutral hip position. On the other hand, if you come in and the feet are angled in, they probably have more medial motion. The other thing we look at is the distance between the ankles or the medial malleoli. If they're further apart, it may indicate the patient has a frontal plane knee malalignment or a higher than normal Q angle, patellofemoral angle, in which there is more of a genu valgum or mild knock knee, which brings the knees closer together and the ankles further apart, which may have a slight indicator of that here. The other thing you can get a sense of, if the foot is strongly plantar flexed, it may be an indicator that the patient's a little tighter through their gastrocsoleal muscles, tend to Achilles, indicating there may be an equinus component. Feet are naturally going to be plantar flexed, but if they seem a little more tense, pointed down, again, that may indicate they're tighter than they should be. So let's begin the exam. The first thing we start with is transverse plane hip rotation. And the first thing I like to do is just get a general idea of total range of motion. And I'm also looking for quantity and quality of motion. Once I've done that, and I've gotten a sense if both hips seem to be symmetrical with the same amount of motion, then I'm going to look at the individual hips. I'm going to start with the right, first with an observational exam. And as I rotate the hip out, I'm actually using the tibial tuberosity as my reference point, and I'm considering that just like the clock hands, that for every 30 degrees would represent a number on the clock. So if I'm able to come out to approximately 11 o'clock, it would be 30 degrees. If I can get to 10 o'clock, it would be 60 degrees, 45 being about the normal, so between 10 and 11 o'clock. Medial rotation, same thing. We're looking at the tibial tuberosity, and we're using the numbers on the clock as an observational guide. Once we've done that, we can do our instrumented evaluation. And the first way we would do it is placing the gravity goniometer on top of the kneecap and holding that stable with one hand. We rotate out and we get the idea of the motion. In this case, we're reading approximately 60 degrees. And then we do our medial rotation, come in, and in this case, reading again approximately 40 degrees. To be more accurate, we can use an instrument which is designed with a cradle to go on the knee. First we zero it. We make sure our tibial tuberosity is directed vertical and we're reading 0. Now we rotate and we get approximately 40 degrees laterally, which is within the normal range. And then we medially rotate the hip to its end range of motion. And here we're reading approximately 30 degrees, so slightly limited medial with greater motion laterally, which would indicate a slight lateral hip neutral position. The next thing we want to evaluate is the femoral patellar relationship, and this relationship between the femur, long axis of the femur, and an axis through the patella, and the tibial tuberosity represents the Q angle. And that angle, which we'll measure with our hinge goniometer, in women will tend to be slightly larger than in males due to the increased pelvic width for childbirth, which will naturally give women a slightly higher genu-valgum. For women, we typically talk approximately 20 degrees for high normal. For men, 17, 18 degrees would be more normal. For this exam, a larger hinge goniometer is more accurate. We have the long axis through the femur, and the other hinge axis coming through the patella. Tibial tuberosity. The angle that we read in this case is approximately 22 degrees, so a little higher than normal, which would indicate that we'll have a little higher knock knee than normal and possibly a little wider base of gait as we see here. And we would do this exam for both extremities because knee alignment is not always symmetrical. You may have a stronger genu-valgum on one side versus the other. The next thing we look at, working down from proximal to distal, is going to be the sagittal plane knee extension. To see if there is any laxity in the knee, we simply place a hand above the patella, holding the thigh down as we elevate the leg. Normally, we may see about 10 degrees of elevation or extension of the leg at the knee. And we always check both sides. And to measure this, we can take our gravity goniometer, and we can measure the angle, and saying between 10 and 15 degrees. And we read approximately 15 degrees, so a slightly high normal. For patients that have greater than 10 degrees, we would expect that they will demonstrate some recurvatus or back knee posture during stance. If they also have a coexisting ankle equinus condition, that tends to further accentuate the back knee recurvatus position. The next alignment we'll be looking at is the possibility of a limb length discrepancy. And for this, the initial portion of the exam involves doing a very simple test called the Alice test. And for this exam, we're going to flex the patient's knee, just lifting, to approximately 60 degrees. And we're going to do both limbs. Very important for this exam to make sure the ankles are close to each other on the same level, that the hips are firmly secured against the chair. Patient may also be totally reclined for this examination, and that the legs are directed vertically and are not leaning either way. Once we've positioned the patient where we feel they're accurately positioned, we can determine if there's a limb length in the tibias where one tibia is shorter than the other by placing a straight edge on top of the tibias and then placing the gravity goniometer. And for normal aligned tibias, they will read 0 as they do for this patient. So we would not suspect any difference in tibial alignment. To determine if there's a difference in femoral alignment, we need to look from the side, and now we're looking to see if the femurs are on the same level when we look directly across, and they appear to be the same. And you would do this from both sides so that we make sure we're not influenced just by the illusion that one's coming out further. In this case, the femurs appear to be in line So no evidence of a structural limb length discrepancy with the tibias or femurs would be noted. And due to the symmetry, I would not measure for a limb length. However, if I did find a difference in tibial and or femoral length, I would next measure. And to do this, we would use a fabric tape measure. And we use landmarks where we palpate the anterior superior iliac spine and holding firmly, we come down and measure to the apex, the midpoint of the medial malleolus. If there were a problem with the medial malleolus due to edema or other problems, the apex of the lateral malleolus could be used, but the same reference point would need to be used for both sides. If we're looking to determine whether there may be more of a functional type of a limb length discrepancy, we can take the same measurement from the umbilicus and measure and look for symmetry to both extremities to the medial malleolus. So from the anatomical anterior superior iliac spine, we're looking at an osseous relationship for structural differences into either the umbilicus or xiphoid process a little higher. We can determine if there may be a functional component. This test and measurement can further be done in stance, where we do the tape measure from the anterior superior iliac spine in reference to the floor, which may tell us again if there's a functional or a structural component. Continuing distally, the next measurement we want to look at is the tibial alignment, and tibias normally have a slight bowing. Approximately 3 degrees to 5 degrees would be considered, 5 degrees being the higher normal. And to measure this at rest, and I like to do this measurement both at rest and during stance, we can use just a standard hinged goniometer, and we look at the proximal half relative to the distal half of the tibia. So we place one arm of the hinged goniometer on the distal or proximal aspect of the tibial crest, and the other arm on the distal aspect of the crest. In this case, we read 2 to 3 degrees, and we can see a very gentle, mild bowing, certainly within normal limits. Higher degrees of bowing or tibial varum would influence foot position, and we would expect to see for higher degrees of tibial varum compensatory subtalar joint pronation and foot pronation. The next measurement that we'll look at is transverse plane tibial torsion, to see if there's a structural torsion of the tibias. Usually this measurement is within 13 to 18 degrees for the adult. If we see values higher than 18 degrees, it would indicate that the tibia is in a higher than normal externally positioned rotation. And the way we measure this is to actually look at the alignment of the medial and lateral malleolus, and we do the axis of the two. Very important for this exam that we make sure the tibial tuberosity is directed vertically so that we can use our reference. To measure this alignment, we position the torsion goniometer, making sure the cups are directly over the apex of the medial and lateral malleolus. And we read this, and we're reading approximately 13 to 14 degrees. So that would indicate our tibial and malleolar torsion to be within normal limits. Another very easy way to get an approximation of the tibial alignment is to place one thumb on top of the lateral malleolus. The other thumb goes right at the midpoint, the apex of the medial malleolus, and the thumb should appear to be on the same level if torsion is within normal limits. If the torsion had been increased, our thumb position would be changed, where our thumb at the apex of the medial malleolus would be higher than the thumb atop the lateral malleolus. If there was a decrease or a lack of tibial torsion, we would note our thumb on the medial malleolus to be lower than the thumb on the lateral malleolus. Again, it's very important for this examination for the tibial tuberosity to be directed vertical, as that's our reference. The next measurement we need to take is to determine if there's an equinus in which we have less than 10 degrees of dorsiflexion available at the ankle joint. For this examination, we use the base of the fifth metatarsal, or the end of the calcaneus laterally, relative to a long axis of the leg. And for this, the perineal tendon usually gives us a nice reference that we can use as a surface anatomy marker. And the first thing I like to do is to make sure subtalar joint is neutral to slightly supinated. And we dorsiflex the foot, and we get a sense, are we making an angle past 90, which we'll next measure. If we find the patient has a decreased ankle dorsiflexion with the knee extended, we would then flex the knee to see if we can overcome the tightness once we've removed tension on the gastrocnemius muscle. To measure ankle equinus, you need to place one axis along the perineal tendon. The other line needs to be in line with the plantar aspect of the foot. Holding that, we'll dorsiflex the foot, recheck our measurements and our alignments. And with that, I'm just shy of 10 degrees to determine if there is additional motion with the knee flexed. You can elevate rather than have the patient lying prone. Next, we can check position again, and here we find we're still tight, still having slightly less than 10 degrees with the knee flexed, which would tell us both the soleus and the gastrocnemius muscle are tight, and therefore we would recommend stretching with both the knee extended and flexed to stretch both muscles. The reason we do not use the fifth metatarsal head as a reference point for the foot is oftentimes we will see that the forefoot is slightly plantar flex relative to the rear foot. And in these instances where we have a higher forefoot plantar flexion, such as with anterior cavus foot types, it will give us a decreased reading of the true ankle dorsiflexion, but it will tell us what contribution to the equinus or pseudoequinus the foot will play. And usually by doing it to the fifth metatarsal head, we'll find reduced dorsiflexion, and that component would be attributed to pseudoequinus coming from the foot deformity. The next portion of the exam is determining subtalar joint axis orientation, and this is a rough estimate just to give an assessment if we have a normal 2-to-1 type of motion at the subtalar joint, whether we appear to have increased motion of inversion, eversion indicative of a lower axis, or whether we seem to be restricted in the frontal plane where we have decreased range of motion, which would be indicative of a more higher axis oriented subtalar joint. In this case, as I invert the foot, I note that the heel is turning in the transverse plane, but I am getting inversion motion. However, when I attempt to evert the calcaneus, I'm very limited in motion, and this would indicate to me that this is a higher axis orientation where we have limited frontal plane motion but increased transverse plane motion, which again a higher axis subtalar joint would be indicative of. The next joint we want to look at to also see if we have a higher than normal axis orientation is the mid-tarsal joint. And for this, we hold the subtalar joint locked in neutral And holding the lateral forefoot, we simply move the foot from side to side. We're not dictating where the foot's going, and we're just watching the type of motion. If the foot appears to be going primarily in the transverse plane, as we're noting here, that also is indicative of a higher mid-tarsal joint axis. If we have a more normal mid-tarsal joint axis, in which frontal and sagittal plane motion are in a one-to-one relationship, we would expect to see more arcing of the foot in the sagittal plane as we're moving the foot side to side. The next measurement to take is the first ray range of motion and the first ray neutral position. To do this, we place the subtalar joint in its neutral position, and we grasp metatarsal heads 2 through 5 with one hand. With our free hand, we place the thumb at the same position on the head of the first metatarsal, and we dorsiflex to the end range, and we plantarflex to the end range. In the normal situation, we would expect to have motion with approximately one thumb up and one thumb down. However, in this situation, we can see that we have more motion up, approximately 1.5 thumbs above the second metatarsal head, and not even quite 1/2 thumb down. A thumb being approximately 10 millimeters or 1 centimeter, we would guess that we have approximately 5 millimeters down of motion and approximately 1.5 centimeters or 50 millimeters of dorsiflexor motion. This would be indicative of a dorsiflex position for the first ray. We would then check the opposite foot, again maintaining subtalar joint in neutral, holding firmly on the second metatarsal head across the lesser metatarsals. We would determine dorsiflexion, and again we see a similar situation where we have greater than a thumb motion dorsally and less than a thumb plantarly, again indicating a dorsiflex first ray position. The next measurement that we look at is the amount of dorsiflexion at the first metatarsal phalangeal joint, which is available with the patient sitting at rest. Ideally, we should see greater than 65 degrees of motion relative to the first metatarsal and the hallux alignment. In this case, we can clearly see that there's greater than 65 degrees, closer to a 90-degree relationship. When measuring this assessment, we take the hinge goniometer and we place the axis of one hinge along the long axis of the first metatarsal. The hinge of the goniometer goes right at the joint, and our other axis goes along the hallux axis. We then dorsiflex the hallux, and we measure the amount, and this shows us at approximately 85 degrees, so certainly adequate dorsiflexion. During stance, we'll measure this relationship again to see if we're limited in the weight-bearing situation, which could indicate ground reactive forces, or dorsiflexing the first ray and limiting motion, creating what would be called a functional type of hallux limitus. The next measurement we want to look at is the forefoot to the rear foot relationship, and we're going to use the flat plane of the rear foot for our reference and the plane of the forefoot as our other reference, using metatarsal head 5 through 2, although if 1 is higher than 2, we can use the full length. We have a plantar flexion deformity in which the first ray is below the second metatarsal head. We should do this measurement from the second metatarsal head to the fifth. If in this case, where the first metatarsal is at least at the same level as the second metatarsal head, we can use the full length of the forefoot. To do this measurement, which represents the mid-tarsal joint relationship, we put the subtalar joint in neutral. We lock the oblique mid-tarsal joint by slightly dorsiflexing the foot. We can see that we have a solid neutral alignment. Next, we're going to place the hinge of the goniometer on the 5th metatarsal head and the other arm on the 1st metatarsal head. We then, sighting down to the heel, open up the goniometer till it's perpendicular to the heel. And in this case, we find that we have approximately 5 degrees of inversion relative to the heel. We would then try to determine whether that may be of a positional nature or if it truly is a structural rigid forefoot varus or inverted forefoot to the rear foot. We would next do that on our other foot to see if we have a similar relationship or a different relationship. While we're looking at relationships such as forefoot to rear foot in the frontal plane, we should also do an assessment of foot reference borderlines for a morphologic evaluation to note if there's any adductus or abductus of the foot. Typically, we expect to see the plantar lateral reference line is relatively straight, which it is here, and fairly straight plantar medial borderline, which it also is here. So we do this on both feet, and we want to check the right versus the left, as feet may be different. We may have adductus or abductus deformities on one foot versus the other. For this measurement, we look at the plantar medial borderline, which should be relatively straight in the normal foot. If we see a break inward towards adduction, that would be indicative of a metatarsus or a forefoot adductus. If we see a break outward, that would be indicative of a abducted forefoot. The next thing we look at is the sagittal plane reference borderlines of the foot. For this, we utilize plantar medial borderline, which would normally be relatively straight with a mild concavity through the arch. In foot conditions in which the forefoot is plantar flexed upon the rear foot, we'll note a slight increase in this plantar medial borderline so that the relationship may be a little greater than it would be in the normal foot, as we can see here. We would also look at the plantar lateral relationship that we talked about earlier for determining ankle equinus and pseudo-equinus conditions. And we would look at the reference to the heel, plantar heel to the plantar forefoot, and the angulation of this plantar lateral borderline, which is normally relatively straight in anterior cavus foot conditions, will be higher than normal, 5 degrees or greater, which we see here. The next measurement we'll be taking is to determine total range of the subtalar joint, and then also the neutral position of the subtalar joint. We need to make a reference line on the posterior leg. To do that, we envision the leg not as three-dimensional, but simply as a two-dimensional object that we're simply going to bisect, which we can do with a ruler or the edge of our hinge goniometer. So that represents our leg bisector. The next thing we need to do is to make a bisector of the calcaneus, or what's referred to as the tuber axis. To do this, we can first place the subtalar joint in neutral position. Then we place the forefinger firmly against the medial aspect of the calcaneus. With that, we next look at the flat area below the lateral malleolus, and we look to see when both the line made by the forefinger as well as that plane below the lateral malleolus, when we're in subtalar neutral, are collinear or parallel with one another. Next, we're going to make 3 dots that coincide with the 2 areas that we're looking at. If we don't like the position of one of the dots, we can change it before we make our line. The 3 dots should be parallel with the interface between the finger and the flat dell below the lateral malleolus. When we have achieved that relationship, we're simply going to make a line through our 3 dots to have our tuber or calcaneal axis. And that will be our reference for determining inversion motion, eversion motion, and our subtalar neutral measurement. To do this, we place the arm on the leg bisector, and we open up the other arm until it's parallel with the heel bisector, as it is here, and we read this out as 3 degrees of subtalar inversion. When we do our range of motion assessment, we maximally invert the subtalar joint. However, note in this instance, we see the heel pulling back or kipping upwards. That indicates that a lot of this motion is occurring in the transverse plane and is not purely frontal plane. So anytime you see the heel tend to come back at you, that again could be indicative of a higher axis. And also, as you evert the subtalar joint, you appear to have very limited motion. And again, that's because you have limited frontal plane motion, but you have adequate, but actually increased transverse plane motion. So feet that appear to have very limited eversion range of motion, that tend to pull back, again, represent higher axis foot types, such as seen with anterior cavus foot. So now for our postural evaluation, we want to see if our findings correlate with what we're seeing during stance. And so on our examination, starting with our hip position, we had relatively normal motion, medially and laterally, so we would expect our patellas to be directed straight forward. If we had patients with a higher degree of lateral hip rotation, we would expect the patellas to be positioned more externally, and with greater medial hip rotation, we would expect the patellas to be looking towards each other, sometimes referred to as cross-eyed patellas. Here we can see again they're relatively straight ahead, so that would tell us that the hips are functioning in fairly normal neutral alignment. The next thing we look at is the relationship of the femur to the tibia, the femoral patelloangular Q angle. And in this situation, you can see on the right that we have a slight increase in that angulation relative to the left. You can see how the tibia comes out more on the right side, and as a result, it increases our base of gait slightly here. Tibial alignment looks to be within normal limits. We do see the slight bowing of a few degrees that we measured. From the side view, if we look at the relationship of the femur to the tibia, we see that the knee is tensely pulled back. We do have slight genu recurvatus. Another finding that we see is that we also have tibial recurvatus. So we have a bowing in the tibia in the sagittal plane. So not all of this apparent back knee contour is coming from just the hyperextended knee. Some of that's from structural bowing of the tibia itself in the sagittal plane. As if we're lacking in dorsiflexion with the first metatarsal phalangeal joint during stance, and we do see that the foot's rolling in, bulging medial. You can also see there's a shift of the ankle medial on both sides. So we can see that we have increased pressure borne at the joint. The hallux is rotated in, the arch has lowered. So we know the first ray is dorsiflexing due to pronation, and also a shift of weight more medial. As we dorsiflex the hallux, we can bring it up, but it's somewhat challenging. We're having to overcome the weight, but we do see a recreation of the arch, and we are able to dorsiflex it. I would say some degree of functional limitus does exist due to the pronation. However, It's encouraging that we can overcome most of the pronation with dorsiflexion, which tells us that improved alignment therapy, just roll your foot out. As we place the foot into neutral position and then dorsiflex, we can see we can much more easily achieve our desired amount of dorsiflexion, and we have a much better arch contour and relax. See the foot roll in. Calcaneal stance position. We note that our heel bisector is very minimally everted. So based on this bisection to the leg and to the ground, it appears that our subtalar joint is minimally pronated. However, if we look at the ankle alignment relative to the lateral heel fat pad, we can see how much medial deviation there has been of the ankle relative to the fat pad. If we place the subtalar joint in neutral alignment, we now can see collinear relationship between the lateral malleolus and the lateral heel fat pad. We see the subtalar joint has inverted slightly, showing the subtalar varus position that we measured previously, but also pointing out the importance of understanding and appreciating that with higher axis subtalar joints, we will not see much calcaneal eversion, relax. However, you will see significant deviation of the ankle joint and bulging medially and collapsing of the arch.